Yeah, so these slides were prepared by Seba. So I'm just going to be reading work that was done by Seba. And so, as he told me, this was a patient who was attended by other colleagues of ours, and he found it interesting, and therefore he prepared it for us to learn from the case. So, Joseph is going to discuss the case today. Joseph, are you ready?
Yeah, I'm ready.
Okay, so we'll start. So this is our introduction. So we have a 27 years old male who presented with headache for 2 months.
Oh, is this the only complaint?
Yes, this is
Okay,
the only complaint that we have.
sure. Yeah, thank you very much. So excited to be back here. It's like 3 weeks I was away, and feels like a year. I can tell you. Yeah. So, uh, usual complaint that I'm telling you, if you sit in a clinic, you must see headache. You must. All these years that I've been working as a physician, I see headache every day. And but before the complaint, you look at the age, you say this is a young person. And we say, if you say a young person, there are things that you should consider. You, you think of stuff like that are related to behaviors of the individual, sexual activity, drugs. You think of genetics. Then you think of sometimes bad luck. 27-year-old with a disease that you don't expect them to happen in a young individuals, but it happens. So think of headache itself. Once you have a person with headache, you put it into groups. You say the secondary or primary. Secondary is easy because you have to find out what's the thing that's causing the headache. And there are so many things. There are so many things. And in this secondary category is the one which will ultimately maybe lead you that are you doing imaging or not to the brain of this individual, because the biggest thing that's sitting inside the head of the person. But there are other complaints. Everything can present with a headache, from being tired, stressed, having a malaria, having a flu, wherever it present with that. Primary headaches, I know we've talked about them here, from tension headache, migraine headache, and the group with like 5 types of headaches. I think trigeminal stuff. If you come back later, it's out of my mind right now. So I think we should move on and hear the HPI, which will lead us to decipher. We were talking about primary headache or a secondary headache.
Yeah, good introduction. So you know, Seba's cases are always very detailed. So I'll try and be fast. So this headache was present for 2 months, as I said earlier. It involved the frontal as well as both temporal regions and around both eyes. It was of gradual onset, dull in nature, persistent, fluctuating in severity from moderate to severe on a scale of 10, around 4 to 8. Initially relieved by paracetamol, then paracetamol plus diclofenac, and then not relieved by analgesics. It was aggravated by straining and bright light. He could not perform his usual daily activities. It was accompanied with eye pain, which was persistent with fluctuating intensity. It was dull, extended to the temporal area. However, it did not involve the retroorbital area, and it was not associated with redness, tearing, loss of color vision, or worsening of visual abilities. And the headache was also associated with vomiting of recently eaten food, and it was non-projectile. Also associated with fever, which was there around 2 days prior to admission, low grade, and with no specific periodicity. However, this patient had no dizziness, pulsatile tinnitus, neck or back pain. There was no auditory disturbances prior to onset. He denied abnormal skin sensation, trouble speaking, or confusion. prior to onset of the headache and no cough or nasal congestion. He had no history of head trauma, exposure to bed droppings, no skin rash, change in skin color, tightening, hardening of scales, no ear discharge or pain, no throat pain, and no nasal discharge. He had no history of hair loss, nail changes, bone pain, joint pain or swelling or ulceration, dry mouth or dry eyes. And he had no history of use of steroids, chemotherapy, radiation exposure, open TB contact, unintentional weight loss, drenching night sweats, no history of multiple sexual partners, intravenous drug use, tattooing, or hepatitis B vaccination. The review of systems was unremarkable. Past medical history was unremarkable. And family social history was also unremarkable. Back to you, Joseph.
Yeah, these are very good residents, I believe. So they're so meticulous. They've taken a very nice history, and they've made me learn the things whenever these cases are presented from David or Seba. I jot down some stuff because it's easy to lose focus. So yeah, this is a headache of 2 months happening in a young individual, and being 2 months for itself, if at the end you decipher that you think it's a primary headache, it should have been new onset. If you look at I think international classification of headache syndromes, most of them should cut at, I think, 3 months. So it will be hard for you unless you tell a patient to come back and back and back. But you hear this history. The number one thing here in this talk is we should do everything to rule out secondary headache, everything. And then if there is no, I will never label this as primary headache, even if I don't have a secondary cause. I'll say probably new onset, that's primary headache, go back and we'll see what's happening. But that's not the case because, as you can see, there are a lot of associated features in this headache. To start with, is this headache is troubling this individual, like moderate to severe in terms of severity, and then it seems progressive in just these 2 months because initially it was responding to one anti-pain, two anti-pains, no response. This is the thing which is progressing. Tells you that whatever you're doing, at the end of the day, you have to come up with secondary cause, because secondary cause, the one that will be progressive. There's no primary headache which progresses. And the fact that bright light straining worsens the headache is also of particular importance because is the headache associated with the neural functioning of the eyes, for example. The neurology of the eye is an extension of the brain. It's an extension of the brain. So the brain sits in the head, and then you're telling us about symptoms associated with the eyes. We have a question: is there something happening in the brain? And then there is vomiting. Vomiting is non-specific when it happens on its own, but if there is another thing, then you should tie that vomiting to that other thing. What do I mean here? For example, I have a diarrhea, and then I have a vomiting. So gastroenteritis. I have malaria, and then I have vomiting. Say vomiting because of malaria. But this patient is primary complaint headache for 2 months, and then there is vomiting. So we should tie the vomiting to the headache. And when we talk of headache in secondary causes, there will be the cause that comes from anything sitting on the head or in the head. On the head, talk about eyes, the ears, the teeth, and inside we have the brain, we have the vessels of the brain, we have the coverings of the brain, everything there. So if you tie vomiting with those structures, one thinks of increased ICP. So you start asking yourself, is this headache of 2 months because of increasing ICP that is progressive from requiring responding to anti-pain medication to not responding to anti-pain medication, and to the point of causing vomiting by triggering the probably vomiting centers in the brain. So that's it. But on top of that, there is fever. The way fever is written in the books that we read here, that are written, most of them are written in the US, is not what we see when we sit in the clinic. And if you have ever sit in the clinic, even for a day, you realize what I'm saying, because someone comes and telling you they have a fever, and if you translate of what is written in your books, you say, okay, they have a temperature above 35.5, which will not be the true. You have to ask, what do you mean by fever? And you find patient telling you, my fever when I have headache, or because I have back pain, that's why I'm in a fever. So when I see this patient is saying they have a fever around here, I put a question mark, what do they mean? But if really, because there is no practice of patients maybe taking their temperatures at home, except for kids. Parents nowadays know they have a thermometer at home. They take their temperature when they come. They say, oh, they have a 39 centigrade. They have a fever. But adults, no. So when they say they have a fever, I don't know what they mean. But if truly it would turn out to be that they have a fever, they or what they mean is the chills, they mean the fever, that's another thing to add in our bucket of problems that we have, because we'll be talking about headache with problem, raising ICP, which is progressive, and then there is a fever. And the fever, you have you don't have to strain too much. If you see a fever, say infection, unless proven otherwise. The unless proven otherwise part is very difficult around here, because we lack a lot of labs to prove that there is no infection. For example, you cannot test virus in your hospital, I believe, wherever you are in this country. Like, say this patient has some viral infection, you just guess, and maybe they have viral infection because you don't see any bacteria growing. So if we say increased ICP, probably plus fever, infection, where is the infection? Infection inside the brain. And what sits in the brain, the coverings of the brain, the meninges, the vessels, the brain parenchyma itself, which can of those can be infected, for example, for 2 months. This is a chronic disease. You cannot say this a bacterial meningitis. That's acute illness, or a viral meningitis. That's acute illness. So for the meninges to be infected, we're talking about some bugs, say someone who is HIV and crypto, for example, that can come in. It's a chronic illness, headache, photophobia that is being said here, plus at the end of the day, raised ICP, because the bugs block the channels that the CSF passes, and there is a raised ICP. But that's a guesswork, all of that. But guess what? That is tailored to what is David is presenting here. So we think of the brain. What's the infection of the brain that can come up this way? It's hard to say. But again, I go back and say, even this fever is questionable. Is this truly a fever? But we'll see. So if it's not truly a fever, maybe they say it's a fever, something else. Then there are other stuffs that can be sitting in the brain and causing this. So a tumor can sit in the brain parenchyma, for example. The blood vessels, there can be a lot of pressure in the CSF, and cause probably primarily raised ICP of no cause. There is nothing that you're seeing, but if you see the CSF pressure is so high. So that's where we are. But at this point, there is nothing to do. But if I'm seeing this patient, I already know what I should do. This patient must get an imaging, and if there is nothing in the imaging, CSF. Plus, because we are talking about Tanzania, HIV burden is high around here. You do an HIV test. As we said, it's young. Risk of HIV is high at this age. So I think, David, we should proceed on that.
Very interesting discussion. I hope people are taking notes. So we proceed to exam, which you've already discussed all these components of history. So we go to exam. On general exam, this patient was conscious, febrile. He was not pale, not jaundice, no oral thrush, no palpable peripheral lymph nodes, and he had no lower limb edema. The respiratory rate 18, starting 96 on room air. He was a febrile, temperature 36.9. The blood pressures within normal limits. Pulse rate 84, a BMI of 21.3 kilograms per meter square, and an RBG of 5.4 millimoles per liter. So on CNS exam, higher centers, he was fully conscious, oriented to time, place, and person. Speech and language were normal. He had normal cognition, and all other parameters were normal. No signs of meningeal irritation. Cranial nerve examination, I do not see anything remarkable here, just to save time. And the rest of the systemic exam, respiratory, abdomen, MSK, as well as CVS were all normal.
Yeah, very nice. So, if you summarize the general exam, or you summarize all of these exams, is normal findings. But the patient is sick, 2 months of headache that are not responding to analgesia must bring a patient to the hospital. However, how much they avoid hospitals, they must come. So they need help, even if you've done your exam and you're seeing they're normal. So patient told us they have headache, and then we do temperature because we want to to like to we say the definition of fever is the elevated temperature, and we do our temperature. It's a febrile. So do they have fever or not? You still can't know because probably they've taken antipyretic, they've taken a paracetamol in the morning, and then you're doing your temperature, and then it's normal. But still, fever, even if it's there, is something that is not necessarily to be present the around the day. Like there are times it can be there, and there are times it can't be there. And sometimes they will say fever because they feel it just at night. That's why you have when you ask a patient about TB, you say night sweat, and the reason is because your body temperature, the normal physiology of your body temperature reset is that the thermostat that's in the brain to control the body temperature goes down when you sleep during the night. So let's say your temperature, you have an infection in your body, and then, but it's so low grade, like 0.1 or 2 centigrade. During the day, you're not feeling anything, but when your thermostat goes down, you start feeling it because now it shows up. That's why we ask that thing. So still, we cannot say, even if the temperature is normal here, the patient is told that they have fever or not. Still, we can't know unless they have the thermometer at home and they've taken it, or we have asked them, did you take an antibiotic this morning? And then we see it's not there. But still, however, they don't have, and they tell us fever, and they mean something completely, something else, unless we ask them, what do you mean by fever? Um, I've touched about my feelings that probably we're dealing with infection of the meninges here, that's chronic, but we're told the patient has no signs of meningeal irritation. Does it rule out that the meninges can be infected in this patient? The answer is no, because the Brudzinski and kerning and neck stiffness that we learn very good. And when you are doing your exams, you ask, do kerning, you do kerning, you do Brudzinski, and when you see patient, you do them. These things, you read about their history, it was in the 1950s in the US. So these are the people who would go in the hospital very late, and these signs will show. So this is another teaching point that you've seen your patient, you think they have meningitis, but you say the Krenning and Brzezinski are negative, so they don't have meningitis. That's not true. Some neurologists say these things are just their historical. They don't even want to hear them. They say this, that's historical. If they are there, very nice. It increases the chance that you're dealing with meningitis. But if they are not there, you never rule out meningitis by these things. You have to tap the CSF, send it to the lab. That's how you'll be ruling out meningitis. So still, they're not, even if they are negative, they're not taking us away from thinking probably the meninges are also implicated here. The CNS exam, very nice. Is normal findings. A patient is complaining of headache. This is not surprising to me because think of think of think of diseases of the CNS that you see and you have findings on exam. Most of them, it's not headache. Just think of them. It will be things like unilateral limb weakness or like lower limb weakness, bilateral lower limb weakness, things like numbness, paresthesia that you do your exam and find them out, or double vision, stuff like that, that lateralizes, like pick a focal point. But headache, usually you don't see findings, so it's not surprising. Still, it's not taking us away from doing the investigation that we intended to do. And yeah, so I think I should not waste most of the time. We should go to the labs and imaging, and then I believe.
So I'll pass you through the investigations very slowly, and I think I should just let you uh, scan through them quickly, and when you are done, just let me know so I can move to the next slide. So the first slide here is the CBC. If there is anything of note here, you can note it and then let me know whenever you are ready for me to go to the next one.
So I think the easier way would be which ones are out of range. So I think the WBC 18, right?
Yeah. So the first one was 18. So there are two dates here. The second column after the first one where you have the items, the second one was done on the 26th of March, and then the other column that was on the 3rd of April. So you have two different readings on different dates.
That range, I think, is it normal that the 526
Oh,
of WBC?
yeah. So I'm not sure about the machine here, but this seems very unusual. So commonly, it's somewhere between 4 and 10.
Yeah, exactly.
Yeah. So I think this was so the WBC here. I think the first one was elevated, and then even the absolute neutrophil count. The,
Okay.
the second one on April, the total WBC count seems to be normal. The WBC is slightly elevated.
Okay. Yeah, and the HB is normal, right?
Yeah, the HB is normal.
Normal the platelet. So the only elevated thing here is the white count and the absolute neutrophil count, right?
Yeah, and then there's this other one, the lymphocyte. Although the absolute lymphocyte count was not included here,
Sure.
but you
Yeah,
can
it's
look at
low.
the percentages.
Yeah, I think the percentage is low, right? Consistently low, the
Yeah,
two counts. Yeah.
yeah.
Yeah, sure. So we can move on the next labs.
And then on this one, an elevation in the CRP and DSR. Other seems to be within normal range, MRDT negative, and blood culture no growth. The chemistry is creatinine, B1, the potassium, sodium, magnesium, calcium, phosphorus, as well as chloride, all within normal limits. And then another set of chemistries here: liver enzymes, AST, ALT normal, GGT normal, ALP normal, T bili as well as direct bilirubin all normal, albumin normal, PT, INR, nothing significant. And then you have serologies here: HIV 1 and 2 negative, toxo. So these are serum toxo negative, CMV, EBV, hepatitis B as well as C. So all these are negative. And then, so unfortunately, I see this. We did not have a video that was seen, but then this is a brain MRI. If you see anything significant on this one, your interpretation.
Yeah, so I don't answer. I'll wait for the official reading from radiology.
Yeah, so I see a note that was here is that there was some abnormal leptomeningeal enhancement. That is what I saw from the report here. So that's what we have for now. Maybe this is where you point out any thoughts, and then any other investigations that you need to order in order to see what is going on.
Yeah. So yeah, good. I think so. Let's start with the labs. Pretty cool labs. So a white count that was raised at one point, and then it's normal in the next. What should we do about it? So a raised white count. I think David and I and other people finds this, and we don't know where it came from. Of clinicians going in the hospital finding raised white count and saying they are infected and dashing antibiotics. It's not a right thing to do. A raised white count. The question is why there is that white count. I'm telling you, a patient with a heart attack, if you take their blood, they have a raised white count, and there is no infection there. So a raised white count, at most, it can tell you patient is inflamed. So it's truly the most common cause can be infection, but not necessarily. So like this patient who is telling us they have fever, they have headache, imaging is telling us they have enhanced meningeal irritation. They are inflamed. Their meninges are inflamed, probably. So it's not surprising that they have a raised white count with a raised absolute neutrophil count. If you see a reduced lymphocyte, number one cause around here should be HIV, but HIV is negative. What else can it be? SLE also present with a reduced lymphocyte count. But does this picture look like SLE? Never. Doesn't look like SLE at all. So what's causing it? For now, probably I don't know. Maybe there is another cause that is causing the reduced lymphocyte count. CRP-SR raised, still the same thing that did raise the white count at that moment. The thing that's causing inflammation is also causing the thing that causes inflammation is causing elevated white count, CRP-SR. The question around here will be, what is that? Still, I don't agree with people doing Siramada. I still don't agree because I don't see it anywhere. I don't see it anywhere. If you search, you see some studies are from India, But if you read the major guidelines, you realize, and it should take you away. For example, if you're telling me this patient is a normal serum ADA, so no TB, that's not right, because that's not the way you say, that's not the way you try to establish the diagnosis of TB, of extrapulmonary TB. Plus, you cannot you cannot completely rule out the diagnosis of TB unless you've given medication. The closest way is to give medication and see the response. The only caveat here there is when the bug is also resistant to the anti-TB medications. So still Siramada is not helpful here. HIV negative, very, very helpful in this young age. So, and still, and now I'm sure if it is not HIV, what is it? Toxo being negative highly reduces the chances that you're dealing with CNS toxo, but still you do imaging, there is no lesion. If toxo was negative and we saw lesion here, the job will be very complicated, and I can say I would have to look up, because I have to look up how is that going on. So another teaching point I think we should make here before we progress is, you see patients with headache, you know, to which one you should do imaging and to which one you shouldn't. I forgot to mention, but every one of us should learn of this mnemonic called Snoop. I remember Snoop. So if you see headache and you think, should you do an MRI or not? Think of Snoop. Think, is there systemic signs in the patient? And here we are told there was fever. Whatever the patient was feeling and saying fever, that's a systemic sign or systemic symptom. So it qualifies. If there is other neuro symptoms, is there neuro symptoms in this patient? Yes, the patient told us they have photophobia, so you should do imaging. And then the new onset. If David told me it's 2 years of headache, I'll say, why did they do this imaging? Because this maybe is primary. But this new onset, still not 3 months. And then, so the S is for systemic symptoms, the N is neuro symptoms, the O is the new onset. And the other O should be old age, I think. Yes, should be old age above 50. P is pregnancy. Yes, a pregnant patient with a headache, you should do imaging, because these patients, they are young, they can have cerebrovenous thrombosis. So the imaging will tell you. So I agree with this clinician who did headache, because around here, everyone with a headache gets an imaging if they are capable, which is not right. So the most important finding in this patient's imaging is the leptomeningeal irritation, which means it's either the meninges are inflamed or infiltrated. Shouldn't forget about that. Inflamed or infiltrated. Inflamed by what? The things that cause inflammation, they're not hard. Most of them, there are 3: infection, autoimmunity, malignancy. Infections has to be chronic infections. They can't be acute infections of 2 months. So chronic infections, we've said, will matter most depending on the status, the immune status of the patient. Being told they don't have HIV, they don't have diabetes, so their immune status is stable, very stable immune status. And there now, which infections? HIV has been ruled out, but there are chronic infections. Patients who are not immunocompromised can have crypto, but it will be a case report. So we go with the epidemiology. The thing that you should think of this patient, because it's in this country, should be TB. Should be TB, number 1. So do whatever you do, but you have to, when you send your labs now, if you have that ADA, send also CSF ADA. And again, another infection, so TB, crypto, yeah, I think I only have those. Autoimmune diseases, SLE can do that, but we didn't see anything else concerning SLE. Adult onset steel disease can do that, but we didn't see anything of the joints around in this patient. So I can say less likely. And then they are male, 27-year-old male, less likely to have an autoimmune disease like that. Cancer, we didn't see any localizing sign that can be causing that there is a cancer, and then they have leptomeningeal mets of the cancer. We didn't see. We will screen them because they are male. We have to go to the genitals, do an ultrasound and see, because there can be something there which is sitting there quietly, and you have all this. But it's likely. So for now, I would say it's an infection. What is it? For it to be, I have to do the CSF. But what about infiltration? So yes, there can be infiltrative diseases, that can infiltrate to the uh, to the lepto meninges. I don't think if I can call any, because I've never seen a case. I've read that if you see leptomeningeal enhancement, think of two things: infection, two eyes, infection, and infiltration. If there is another eye, I think I'll have to check, but at least those. So, which infiltrative disease that can infiltrate the meninges? So, cancer can do that, yes, maybe, but others like hemochromatosis, I don't think so. I think we don't see anything about hemochromatosis here. Yeah, so maybe someone else can check them. There are infiltrated disease of the meninges, and will tell us in the charts. But for now, I'll, should I do CSF or not? I should do CSF because I'm not seeing anything in this imaging that is telling me there is a contraindication of doing CSF. So I'll tap and send in the lab. Among the things you send is to test for TB. And yeah, I think we'll be doing with probably TB meningitis based on the epidemiology and based on what we're not seeing anything else. The differential diagnosis on that, um, I'll have to learn from you guys if there's a differential diagnosis. I think David, now I'll take the CSF and test for TB meningitis.
Yeah, interesting discussion, and I mean, if someone is writing uh, lots of pages to write from your thought process. Antimon was asking about CSF analysis, and Joseph also wants that. I think I'll project that in a moment, and then Aman was talking about neuropsychiatric history of the client and any history of feeling depressed, overworking, or psychotic history. So the review of systems, the past medical history, there was nothing suggestive of that, no neuropsychiatric symptoms. So apart from the headache, there was no confusion or anything else, any mood symptoms, so to say. Yeah, so here was the CSF analysis. Appearance was clear, opening pressure high. I see it was not recorded here. A slight elevation some elevation in the CSF protein, and then low CSF glucose. CSF CRAG was positive. Culture and sensitivity, no growth. Cytology was acellular. Gene expert negative. ADA7. The serum glucose, we already talked about it, and the ratio was 0.15. And then another thing that was done was the CD4 count, which was 232. IgG levels not done, but autoimmune profile was negative. Yeah, so Joseph, any thoughts based on these additional pieces of information? Joseph, if you are speaking, you are muted.
Yeah. Sorry, can you project again the previous slide that showed the initial CSF analysis? Yeah, so yeah, very, very important. So high opening pressure, as we said initially, uh, we thought the patient has raised ICP, which is true. We're being told here on high opening pressure. For those of you who are in the hospitals and then you say you can't do eye opening pressure, I can tell you Seba and his colleague, maybe they didn't have the thing to measure, but you can do it. If you do your, you take your giving set and then you connect to your um, the cannula that you are using, and you can see how it rises, and use a Lura. So it's easy. Make sure that you do that. I believe you can say we don't have the instrument, but you can do that. We were told that by someone from the US, and we were here. We said we can't do because we don't have a burette to test. So that's not right. Another thing that is out of range is the glucose. You know, when you're told when you see low glucose, think of bacterial meningitis, but no, bacterial meningitis is an acute disease, a chronic. So I'm not sure about what TB looks like. So the crack being positive, well, it says this crypto, and there's no question about that. But I say it is possible for an immunocompetent person to have crypto, but it have to be a case report because it's unheard of. Personally, never seen it. This would be the best case. There's the adult 7. So what's the cutoff point, David, on the CSF?
Yeah, I'm not sure about the cutoff in the CSF, but so for the fluids, commonly talk about things above 40. I'm not sure if
Yeah,
if it's the same with the CSF, but the normal range was not recorded here.
yeah. So yes, so if you do CSF ADA, that's the thing to do, which is very good. So when you were discussing, I have these. I think I'll find them out where I put them, but I have the cutoff, and I can tell you what the sensitivity later. I look them up. I look them up. I have them in my notes. So it can't like rule out TB, but it comes very closely than anything else. This extrapulmonary TB of the fluids, like the CSF, the ascitic fluid, the pleural fluid, you do the ADA, it comes very close. The thing that is proven to show, at least, it was so hard to diagnose the thing. But we won't spend much time there because we have a positive drug. So I think, yeah, this is a very rare case of um, cryptomeningitis in an immunocompetent individual, very young at this age.
Yeah. What are your thoughts on the CD4 count?
Oh, I didn't say that. Okay. Uh-huh. 232 is you mean this is below range?
Yeah, yeah. I think this is
Yeah, it's at
below.
500. It has to be above 500.
Yeah.
Uh-huh. Yeah, I understand. So in a patient like this, you should go on. You shouldn't end up there. But yeah, very nice. Thank you very much for pointing me that. I didn't even think about it. I realized you did CD4 and you find this normal. So this is pretty abnormal. I have to be above 500. Yeah, so in a patient like this, again, as I said, uh, cryptomeningitis and in an immunocompetent individual has to be a case report because it's so rare. So do everything to prove that they're immunocompetent. So with a low CD4 count, uh, the thing that can reduce CD4 count is either you have a genetic disease of the immune system, like things like combined immunodeficiency syndrome, for example, or you have acquired the immunodeficiency. We're talking about HIV here. So plus the low lymphocyte count that we saw, I think we have to send the HIV viral load in this patient. and probably we're dealing with HIV, AIDS, with cryptomeningitis.
Yeah, so very interesting discussion, and so with just some thoughts on the HIV, because this patient has been having this headache for about 2 months, and the HIV that was done was negative, and that was serology, of course. But then, with with the current kits that are used, and of course they are just measuring the antibodies, but I believe we do not yet have the fourth generation, the fourth generation HIV, the fourth generation HIV kits, which are measuring the antibodies, I believe, plus the P24. But then, even with the third generation, uh, the antibodies become detectable in about a month. So the fact that the patient is HIV serology was negative after 2 months, uh, maybe a HIV viral load would not be warranted. So, interesting discussion, and of course, we've come to a conclusion of crypto. And so the thoughts was this patient had idiopathic CD4 lymphopenia, and that is what predisposed this patient to present with cryptococcal meningitis. Of course, this is a new thing even to me. I've just heard it or read about it when I was going through these slides. I've read about the primary immunodeficiency syndromes, but you have there are so many, and I believe the last time I read about, you have more than 200 individual uh, primary immunodeficiency syndromes, and some are combined, as you said. So some will affect a single either B lymphocytes or T lymphocytes, and some others it will be a combination of those, and others you talk about the lymphocytes plus granulocytes. So many of them, it's hard to keep track of them. But because this patient, the CD4 count is what was found to be low, so these were the thoughts that the patient had idiopathic CD4 lymphopenia, and that is what predisposed him to present with cryptomeningitis. So, just a few teaching points that were prepared by Seba, an approach to opportunistic infections. So, if someone presents with opportunistic infections, think about you have so the common, which what we see commonly, because you have to know that immunodeficiency syndromes, the commonest are secondary, basically. Primary immunodeficiency syndromes are very rare. So, on the side of secondary, you talk about HIV, diabetes, malignancy, drugs. You can think about many drugs that are causing immunosuppression, and then radiation exposure. And Joseph discussed about a lot of these things. And then when you come to primary immunodeficiency syndromes or diseases, you have T cell disorders, B cell disorders, combined T and B, and then phagocyte deficiencies. So these were the thoughts, because the CD4 count was done for this patient, and the patient had a low CD4 count. So the thoughts here, idiopathic CD4 lymphopenia. So this is a rare condition which is characterized by an unexplained deficit of circulating CD4 T cells, and this leads to increased risk of serious opportunistic infections. CD4 counts, they are what we call T helper cells, and therefore they are very, very important in both terms of acquired immunity, when you talk of cell mediated as well as humoral immunity. So, in order for you to have B cells that are producing antibodies, you need to have CD4 cells first present triggering a cytokine reaction after some antigens have been presented to them by antigen presenting cells. And of course, in order for you to activate cytotoxic T cells like CD8 cells, you also need CD4 cells, and therefore, a deficiency of CD4 cells will lead to a risk of serious opportunistic infections. This was initially described in 1992 after opportunistic infections that are known to be associated with HIV were found in patients with low CD4 counts and negative HIV results. There is no sex predilection, and the peak age of onset is 40s. This is a thought pathophysiology. You have activation of CD4 cells by unidentified pathogen with impaired homeostasis, presence of autoantibodies against CD4 cells, and then enhanced activation of Fas and Fas ligand. You end up with increased activation and turnover of CD4 positive cells and accelerated apoptosis of those cells, and then you end up with idiopathic CD4 lymphopenia. So these are diagnostic criteria from the CDC. You need to have a CD4 depletion with absolute CD4 lymphocyte level below 300 or less than 20 of total lymphocytes at a minimum of 2 separate time points, at least 6 hours apart. No serological evidence of HIV infection, and then absence of any defined immunodeficiency or therapy associated with depressed levels of CD4 T cells. So this was a treatment for the patient. He was kept on standard treatment for cryptococcal meningitis and then kept on prophylactic fluconazole. Now, the issue of treatment as well as prophylaxis, there are questions about the role of immunization, for in order to protect them from infections, and then of course you need to keep them on antimicrobial prophylaxis, just as in patients with HIV, and you treat the presenting complications in that patient. So that's what we had for today, Joseph. Any reflections from you?
Uh, before I'm very emotional because this is very nice. In this country we have brains here. I don't know this diagnosis, to be honest. I've never heard of it. I've never even read about it. And these are residents, and they came up with the diagnosis. And why am I very happy? Because it's something which is treatable. Imagine if this patient wouldn't have met someone who is capable of reading and understanding and knowing you can have a disease causing low CD4, predisposing you to diseases that a physician like me just think this has to be immunocompromised, like crypto. It will be so hard. Someone like this can die without getting treatment. So if you treat them, they get back, and then it's okay. So I'm very emotional. This is a very good thing, and it also shows why we are here, because this for me changed a lot of things. So I'm thinking now, maybe I've seen something like this which escaped, and then I didn't even catch it because I can't think of something like this. So I encourage everyone, maybe who's watching YouTube or wherever, to spread this word that we have to learn medicine. We have to be serious and learn medicine, because we see stuff like this. So I'm very happy for this patient at the end. Someone to get that diagnosed and treat them. This is a treatable thing. Another is I would say, if I was involved and then they told me about this, I would say, if you think or anything about immune stuff, you should send the IEGG and see what's going on with them, trying to come up. The immunodeficiency syndromes, they are the list I cannot recall, but I remember by combined immunodeficiency because it's common, but there are other very uncommon stuff. So many of them. Maybe there is one that you can see. But I'm very happy I've ran new thing, idiopathic lymphopenia. It can present like this. So thank you. Another thing I told you I would check. So I looked up this, the notes I took during my residence. If you have a CSF ADA, the cutoff point is is 9. So the sense, so if it's above 9, you can say positive. If it's less than 9, you can say negative. The sensitivity of that test will be 79%, and the specificity is 91%. So, for example, here 7 less than 9, and the specificity is 91. Um, that's the learning. I'm very happy today. Thank you very much for bringing this case. Thank you very much, Seba, wherever you're listening, and your colleagues who did the thing. This is very impressive. I love it.
Yeah, thank you very much, Joseph. A lot of learning from you. I mean, from right from the beginning, the way you approached the headache, and then of course, more than once you mentioned the diagnosis of cryptococcal meningitis, and lots of learning points from you. If someone was taking notes, I believe there's a lot that has been written, and a lot to learn from the way you dissected through the case. Yeah, so I was seeing some comments in the chat. Yeah, Antimon came back again with a question of primary immunodeficiency, and you were right. Can we measure the immunoglobulins? Yeah, so I'm not sure if they couldn't measure because they did not record that, but then the patient turned out to have CD4 lymphopenia. Yeah, so are there any comments, any questions, anything to share from the audience? Happy to see Professor Shayo in the crowd. So any comments from anyone before we close? If you have anything to share, any question, any comment, any thoughts to share, you can just raise up your hand and then unmute and speak. Yeah, so I see no hands so far. This was a good day. Joseph discussing a case after being absent for like 3 weeks, and so for those of you who do not know, today is a very interesting day because Joseph is discussing a case just one day post wedding, and that's what I meant when I said if you are not inspired by consistency in learning medicine from Joseph, I'm not sure what will inspire you because this man is in honeymoon today, but he thought of coming here and discussing a case. So I think this is an inspiration to all of us. Uh, I'm not sure if you do not come and learn medicine, discuss a case, or present a case on a Sunday night. I'm not sure how more productively you can use your time, because sometimes it's just 1 hour, and if you do not come here, you can just end up scrolling on Instagram or watching a movie, and I'm not sure what you gain from that. So thank you very much to everyone who joins us for 1 hour every Sunday. We know Sunday is resting time, resting day, but you people are motivated enough to come and learn medicine. So let's keep encouraging each other, whether through this platform or any other means, to keep on learning medicine, because our patients need us, and they need us to have this knowledge and the skills. So I see a lot of congratulations to Joseph in the chat. So once again, congratulations, Joseph, on your wedding, and we wish you all the best. And thank you very much, everyone, for joining. We'll see you next week, and have a good night.
Thank you.